And this should be the slides. Okay. Well, good afternoon, everyone. So very nice. Oops, that's the wrong slide. Let's go there. Perfect. So my name's Stephen Fong. I'm one of the gastroenterologists here at the Conquest. And Kathy said that it would be probably a good idea to do a little bit of education and teaching about managing anemia, which I'm sure all of you see in your hepatitis clinics at some point with these patients that we keep sending you. I mean, the main objectives for me was to give you a very practical way of looking at anemia, how you diagnose it, and how you might then start treatments. And I wanted it to be actually as interactive as possible. So I want you to know I'm very curious about, oops, let's see how this has all come out again. How exactly, what sort of things you're looking for actually. So I was gonna say, Kathy said something about thalassemia, but what kind of issues with anemia do you normally get in your clinics?
Usually it's some type of iron deficiency anemia, so low hemoglobins or low ferritin, low MCV, that kind of picture when we're originally sort of, picking someone up from that perspective. That's the most common. Obviously, we see higher levels in our drinkers and those with hemochromatosis, but it's really along the patients who we think maybe have got some iron deficiency anemia that's not really been investigated in the past.
Can be tricky.
Sometimes
and what kind of problems do you get? Sorry, go on.
Sometimes symptomatic, sometimes not. Sometimes it's that fatigue, but again, that's very much can be a symptom of Hep C.
And what kind of dilemma do you struggle with? Is it more trying to know what kind of anemia, or actually is it more that you know that you recognize that quite easily? Is there a particular part of the anemia that that you guys have any issues with, or?
I think just the blood test results really working out when something's microcytic, that sort of picture.
I think that is, what, you're definitely not alone. That is one of the trickiest parts about looking at anemia, and junior doctors, nurses, consultants, we all struggle with that. So if I can help you with that, at least I think that'll be one of the main objectives from today. So I think this is essentially what happens. So most of you are going to get a referral for someone, hepatitis C waiting for treatment, and you'll probably get a blood range something like this. And the difficulty, obviously, is you got so many parameters that it can be quite confusing. So would you say one of the problems you have is trying to understand which of these parameters you actually need to pay attention to, or is it something else you find a problem?
Yes, definitely for me. Yeah.
Good. Yeah. Well, for me too sometimes. So you're not alone. So this is not exactly true, but it's a funny story that someone used to say to me. So anemia is in the remit of hematologists, and hematologists don't do a lot of work. So to make themselves sound very smart and that they're doing a lot of work, they like to hide between a lot of blood test parameters such as MCH, MCV, RDW. So it makes them look more fancy than they really are. Obviously, it's not true, but there is there's a point to that message, which is you have to know which blood parameters are important for you and which ones maybe aren't so important for you in anemia. So the more you understand what the parameters mean, it's easier for you to diagnose something. Okay, so I think that's one thing you need to keep in mind. So from a practical perspective for you guys, hemoglobin's quite straightforward. White cell count probably is as well, and platelets. Do you guys know what hematocrit is? Can any of you tell me what that means? Anyone?
Is that the concentration of red cells?
It is. But any idea why you need that?
I think I remember once counting on a slide to measure how many red cells per volume, something like that.
Okay. So the problem is sometimes the hematologists like to use a lot of parameters where you might not always need all of them. So the usual blood count or the concentration of our blood in you or me would be around 40 to 50%. Oh, don't know what happened there. So, which is the correct parameter. So it's essentially, like you said, hematocrit is the concentration of your blood. But actually, if you got a hemoglobin, there's an argument you don't really need the hematocrit in a big way. So I think what I'm trying to say to you is it's important to focus on the blood parameters that are most useful, which could be is probably hemoglobin and maybe less hematocrit, but just so you know what that means. MCV is obviously very important because it gives you an idea about whether it's microcytic, normocytic, or macrocytic. How about mean cell hemoglobin? Do you guys use that much at all?
We do test because it comes into the full blood count, so we do test for that.
But do you use it?
I don't. I generally look at MCV to see if it's some sort of iron deficiency anemia. So I don't know enough to probably use that, understand that test.
Absolutely. And the good news is you probably don't need to really know in depth. This is the problem. There are so many parameters, but you have to focus on the ones that mean the most value to you. So I very rarely use the mean cell hemoglobin or MCH in my clinical practice. So it's just giving you a clue that from a gastro side, even we don't look at every single parameter. How about red cell distribution width? Do you guys know what that is?
I don't.
No, I don't.
So your blood cells, they come in different sizes. So some are smaller, some are bigger, but they usually should be roughly around the same size. But if you've got a lot of different kind of anemias, and so you've got small cell red cells and big red cells, the distribution width, as in the variation in the size, gets bigger. So that's what RDW means. From a practical perspective, it just means that there are a lot of different red cells. So something's not quite right with your cells, basically. So that's what it means roughly in a nutshell. Do you need it often? Usually not, but it just helps when you know a bit more what that actual blood test parameter means. Okay.
Yep.
Any questions about that so far? Any other of those parameters you want me to explain?
Did you say
If
red
not,
cell count?
no, that's the red cell distribution width. The red
No,
cell
yeah,
count
what
is
does that mean?
something I don't normally use either.
You won't.
So
Okay.
you see, yeah, there's a lot of things here that you don't always have to use. So for a main jobbing gastroenterologist, because I'm essentially a glorified gastro plumber, I kind of want to know, is someone bleeding? The hematologist is a bit smarter. He wants to know where the blood is being lost and who's making it. But as a general rule, HB is what I use, white cell count, the platelets, and maybe a reticulocyte count. Do you know what that is?
No.
So if you lose bloods, reticulocytes are baby red cells. So, if you lost a lot of blood, your body's got to make more blood. And so it makes a lot more of these reticulocytes. So when you have a very high count, means your body's lost blood. So it's making more of these baby red cells to grow into adult red cells. So you can use that as a marker to see if someone has lost blood as well. Okay. But as you can see here, MCV is very useful. MCH not that useful at all. I very rarely use MCHC or RDW in most of the time. So if you had to focus on what you need, is HB, MCV, maybe a reticulocyte count. Okay. The second thing hematologists like to confuse you with is they love to give you blood film results, which I suspect. Do you guys normally read the blood, the peripheral smears and all that, or not really?
No, I haven't.
You don't have to, but sometimes when you get one of those anemias that's not straightforward, reading the report is a bit helpful because it might tell you what kind of anemia is happening and whether you need a hematologist rather than a gastroenterologist. So this is just a very brief example of the red cells, the platelets, and the white cells. So obviously they all look different. And we can use the blood film sometimes to actually tell us what kind of anemia we're dealing with, particularly if it's a more hematological problem like leukemia or things. So while it's not necessarily something you have to know in depth, knowing a bit about the size and shape and little things that the hematologists like to hide behind can be helpful. But we're not here to do a full blood film lecture. So just to relax, don't panic. You don't need to know that bit, but it's good to know that blood film or peripheral smear is an important part. These are the other things you might need. But the ones that I find most important, especially if you're getting a lot of iron deficiency anemia, is transferrin saturations, ferritin, and obviously folic acid and B12. Do you guys know much about transferrin saturation and ferritin, or any questions about those elements of it?
I think we junior nurses don't know a lot, but the hemochromatosis nurses probably do.
Okay. Ferritin obviously is the big one you use to help tell you it's iron deficiency anemia. But can any of you tell me why ferritin by itself is not always 100% accurate test for iron deficiency anemia?
I don't know. It's iron stores, but I don't really know I can't answer your question of why
No
why
problem.
on its own.
Yeah. So the reason is, you see, ferritin is not just a marker of iron. It's also what we call inflammation or acute phase reactant. For example, if I had, say, COVID or a fever or something, it causes an inflammatory response, and the ferritin can actually go up with that. So even though you had an iron deficiency anemia, your ferritin might look still quite normal because it also goes up with other conditions. So what I'm trying to say to you is that it can be misleading sometimes. And that's one thing you need to know, that your tests, they have some limitations depending. So for example, let's say you had a hepatitis C patient and he had rheumatoid arthritis as well. He was anemic, but his rheumatoid arthritis was flaring up. So he had a CRP of 60. And then you do the ferritin because you think he's got iron deficiency anemia, but the ferritin is 67 or something. Does that mean he doesn't have iron deficiency anemia? The answer is no, because the ferritin has gone up because of his inflammation as well. Does that make sense?
Yeah. Stephen, can I ask the other? So a lot of our patients who drink a lot, so alcohol excess or alcohol dependent, happen to have slightly raised ferritin. They don't always have hemochromatosis, but often see this elevated iron in heavy alcohol use. I don't really understand the reason why that happens, but I know that it does happen.
You're absolutely right. It's for exactly the same reason as I just talked about. So the alcohol and everything causes some inflammatory response in the liver. So naturally, some people with high alcohol intakes, they have a high ferritin, even though they have an iron deficiency anemia. Because the ferritin is not just about iron, it's also an acute inflammatory blood test. So it goes up with inflammation and other medical problems. So that's why your heavy drinker alcoholic, which is something you get so often with hepatitis C patients or hepatitis patients, it goes up too. It's very misleading. So don't worry. That's why you'll be looking at it going like, oh my God, why is his ferritin 300? He doesn't have hemochromatosis. It's acute phase reactant. So that's one thing you guys need to know. So sometimes as a gastroenterologist, what we do is we use little tricks to give us a better idea whether there is iron deficiency anemia. We do a transferrin saturation, because sometimes even though the ferritin is high, but the transferrin saturation can be low. And that might give me a clue that the patient does have iron deficiency anemia. So sometimes you have to use a few different blood tests to confirm if someone has iron deficiency. Does that make sense?
Yeah.
Cool. Now you can do other tests, like some people do urine analysis because 1% of iron deficiency anemia, it can be due to a renal cell or kidney tumor. So sometimes don't forget to do that. It's a simple test to do. And obviously some people, you've got iron deficiency anemia and you need to look for blood loss in the gut, then you might do a gastro or colo or capsule. So there are other things you do, but one key lesson for you is actually learning what kind of anemia you have first before you go for a lot of other invasive tests. So I think we've done too much theory now. I'm going to give you a case and I'm quite curious to see what you're going to do. So you got a 34-year-old African-American woman. She's due to start treatment for hepatitis C, but then you pick up she's got a mild microcytic anemia. And this was actually on the blood test 2 or 3 years ago, but she's totally well with it. She's had high iron tablets a few times, but nothing happens really. It just stays the same. So you do the blood test, and yes, I told you hematocrit's not useful, but they did it anyway. She's a bit anemic. It ranges between 10.6 to 11.4, the hemoglobin. Platelets are normal. White cell count's normal. MCV 72 to 74. So I'm going to put it up to you guys. What do you think is going on? What do you think is the cause of this patient's anemia? How would you go about it? Because the best way is for you to think it through, and if you give me a few answers, you know whether you're right or wrong.
Is that MCV normal or not? Because I don't know what the normal range is.
Ah, that's a
It's
good
low.
question.
MCV is low.
So always remember what the normal range is in your unit. Sometimes it can vary a bit, but it should be 80 to 100 normally. So you're quite right. So it looks a bit low. What else can you tell me? So it's what we call a microcytic anemia, isn't it?
Yeah.
Yeah.
When do you get a microcytic anemia normally?
Is it more dietary? Would you get it just lack of iron, or are you just not making enough red blood cells with a microcytic anemia?
Good. So you're thinking about, and we're going to go through the different classifications of anemia, because that will be the key for you to be confident about what kind of anemia you are. But the main thing to say is she's got a microcytic anemia. So the differentials could include iron deficiency anemia, or it could include some of these other things as well, which you may not be so familiar. Have you guys heard of thalassemia before?
Yeah. I've got quite a few patients with thalassemia.
Where are they normally from? Do they come from a certain area of the world, do you think?
It's Greece, isn't it?
Greek,
Greece.
Turkey. Yeah, I think Greek and Turkey, I think.
Very good. Perfect. Yeah. So thalassemia is very common in certain parts of the world, such as the Mediterranean, Africa, and East Asia, like Thailand and Malaysia. So if you're getting patients from those ends and you get a microcytic anemia, you have to think widely about these things too, because sometimes you think it's iron deficiency anemia when it turns out it's not. These things are not as common, lead poisoning, sideroblastic anemia, but they're all part of what we call microcytic anemia. Okay, so let's just say you pick this up. This is your normal clinic. Dr. Zubair, no gastroenterologist is around because these bloody gastroenterologists always leave the bloody place early. What test are you going to do next? How are you going to try to piece this together?
Would you do that slide one?
Would you just start? I generally just start with ferritin and transferrin saturation and folate, and that's probably what I do first.
Very good. So you always go back to basics. Yeah, you don't have to go for a really rare diagnosis. If you got microcytic anemia and you know a differential of a microcytic anemia as iron deficiency anemia, you want to do some iron markers. So we did do the iron markers. The ferritin was normal. Transferrin saturation was normal. Liver tests were all fine. There was no liver cirrhosis. Thyroid tests are normal. Renal function's normal. And there's no lead exposure because that can give you a microcytic anemia. So they say, let's have a look at the blood film, which looks like gobbledygook. I don't want you to feel you need to give an answer, but look at this picture and tell me what looks a bit different, or what can just describe what you can see on it. What looks a bit weird about it?
They're not all fully formed cells.
You got these funny ones with eyeball like a in the middle, isn't it?
Yeah.
Can you see those?
Yeah.
Yeah.
Does anyone know what these are called?
I don't.
In the hematology world, they call these target cells because it looks like a bullseye target.
Oh, yeah.
Yeah.
The reason this is important is this means this is a cell that is a red cell that's not really well designed. It's not working properly. It's because a normal red cell should look just like this without a dot in the middle. So you know something is not right, and it's because this patient has thalassemia.
Stephen, can you explain the difference between someone's got this thalassemia trait? What's the difference with the trait? Does that mean something to do with the genes, their genetic?
Absolutely.
Okay.
Yeah. So you're spot on. So the next slide is going to hopefully explain to you it a little bit more. But you see, this is your normal red cell, and that's the abnormal one because the thalassemia means your red cells are not designed properly. So that's how you pick it up. But you ask a question which is the most important thing, because even for a gastro doctor, I had to read up about this yesterday, Kathy, just so I could give you the proper answer.
Does make me feel a bit better.
Yeah, so remember, this is the reason hematologists, they hide behind very complex genetics and blood disorder patterns. So that's why it's hard to understand. So don't feel bad about not understanding. Even a gastroenterologist can struggle. You see, your blood is made of like 4 building blocks called alpha chains. And each part of, say, the 4 building blocks is it has to be made by a specific gene. So if you have the thalassemia genetic disorder, depending on how many of the gene problems you have, it will determine how bad your thalassemia is. Do you understand?
Yeah.
Yeah.
So for example, if you have 4 genes working fine, you have a normal blood red cell. It's totally normal. If you are missing one of them, you might be a silent carrier. So you might not see anything wrong with your blood test at all. But the more you have deleted or broken down, that's when you start seeing thalassemia problems, basically. So here, can you see this one? 2 of them are working and 2 of them are gone. And that's when you start getting thalassemia trait. So trait is kind of like, if you know you had severity levels of severe, medium, and low, thalassemia trait is like in the medium level. So you could start seeing signs of anemia. Sometimes the other thing is confusing. They used to use the terminology thalassemia major and thalassemia minor. So major is meant to be a more severe disease where you have more genetic problems, and so you have more need for blood transfusion. Whereas thalassemia minor is normally when you have a thalassemia trait. So you might have a bit of anemia, but it's normally not severe. You don't need to do anything about it sometimes. As you get worse, like here, he's only got 1 gene working. That's called HPH disease. That's really bad. You get a very bad disease. And this is where you have no genes for the thalassemia. This is really bad. This is when you normally the fetus dies and things like that. So what I'm trying to say to you is, depending on how many genes are not working, that tells you whether it's a trait and whether it's really severe. So a trait is normally in the middle where you have 2 genes working and 2 genes gone. Does that make sense?
Yeah.
Yeah.
And it's the same for beta thalassemia. So this is for the alpha chain in the blood count, and you have a beta chain, and a similar principle works in that regard. So what you're seeing with the trait is just that it's kind of telling you how many genes are missing.
Do you
I hope that
transfuse?
helps.
Do you transfuse these patients?
It
Do they receive?
depends.
Yeah. Okay.
For example, like this lady, if she's a thalassemia trait, so they do other fancy things which we don't have to necessarily go into in depth about, but they'll do this electrophoresis because it tells them how much of the normal blood count they have.
Yeah.
And they can read this, but you don't have to do that. That's you know, a bit beyond, but I'm just giving an idea for thalassemia. That's how they look at it. She's got a alpha thalassemia with a double gene deletion. So that's this one around here.
Yeah.
Okay.
Yeah.
And it's a trait. So for most of them, they will have a mild anemia, but it's not progressive. Okay. And they don't normally need a blood transfusion or iron treatment because it doesn't do anything for them. The problem is not the iron deficiency. So the one differential or the one way to differentiate a thalassemia and iron deficiency is, number one, you do the iron markers, and if they're normal, even though you have a microcytic anemia, it probably means, if especially if the story is right, it comes from Malaysia or Africa or Greece, think of thalassemia.
Yeah.
And usually these patients, if you give them an iron supplement, it doesn't improve their anemia whatsoever. But the ones who need blood transfusion is when they are much more severe, when they have a lot more deletions. Okay? So you have a thalassemia major, it normally means they're blood transfusion dependent, but there's a lot of variation in the severity. Sometimes with the thalassemia trait, if they're very unwell, say they had COVID or infection, their blood count could drop and they might need a blood transfusion. So it depends on the situation.
Yeah.
From monitoring these patients, Stephen, so for example, I've got a few patients who've got beta thalassemia trait. My concern is they get so used to seeing them having these low hemoglobins that how often then do you sort of test? So I've had this looked after lady for some time. She's never really been symptomatic, but now she's complaining a lot of fatigue and feeling really tired. So I requested the iron studies on her. But I just worry that we're just so used to seeing, oh, that's normal for her. Her hemoglobin's low and that's sort of normal. It's just, when would you think that maybe it's not the thalassemia? It could be that there is another cause for the iron deficiency. Should we do any more blood tests on them, or is it waiting to see if they're symptomatic? Or just sometimes I wonder if we miss something because
I think that's a really good point. So I think it all depends on the history and the situation. So you got to remember, a lot of these patients, it could just be the thalassemia, but you have to see if something's happened. So for example, if their normal thalassemia anemia is like HB of, I don't know, 100, and suddenly it drops to 70, then something sounds a bit fishy.
Yeah.
And then let's say you do the iron studies, which are normally normal, but suddenly the ferritin is very low, the transferrin saturation is really low, then something else might be happening that's new on top of the thalassemia. So essentially, if you have a new drop in the trend, then stick to your basics. Do the full blood count, the iron studies, the B12 folate, trying to see if something new has happened, and a good clinical history is very important.
Yeah, thanks.
So I think what I'm trying to say is there's no set rule. You have to be a bit logical. You have to be a bit smart. If the woman says, you know, actually this is kind of my usual up and down, and her hemoglobin is roughly the same amount as it always is, and the iron studies are normal, then you're probably less worried. Or if she says, actually, I've had a change in my bowel habits, I notice a bit of blood and, you know, I'm losing a bit of weight, and suddenly there's a new iron deficiency, you have to investigate. So that's how you manage this: observation and clinical suspicion.
Thanks.
Okay. So that's it's a tricky one, thalassemia, but yeah, that's how you do it. So mainly if you get anemia, you got to think about how it happens. It's either you lose blood, or the bone marrow stops producing it, or there's more destruction. So as long as you're thinking along those lines, that's a useful way to do it. I'm thinking before I do that, before I do this case studies, I'll do this. So for you guys, this is probably the most practical way for you to work it. If you got someone with anemia, look at the MCV first, okay? Because that's going to help you most of all. If it's less than 80, it's a microcytic anemia. If it's normal MCV, it's called normocytic. If it's a high MCV, then it's a macrocytic. And usually, but there's sometimes overlap, that points more towards the most likely cause. So if it's microcytic, you want to do iron studies, not just ferritin, normally transferrin saturation, because if it's low, iron deficiency anemia. If the ferritin and iron studies are normal and the guy's from Mediterranean or something, think about thalassemia, and you can do the peripheral blood film and then refer to hematology for genetic testing, and then you might pick it up. If it's a normocytic anemia, then the causes could be different. They can be things like leukemia, so you need a blood film. So as a general rule, you look at the MCV, you might get iron studies and a blood film. Those are for me and folate and B12. These are the basics for a practical doctor or nurse, basically. Then what you do next depends on what you find from that. Are you guys following me so far? Or anything there a bit too much?
No, I'm following.
I'm glad you're recording it, put it that way.
That's a really useful slide, I think.
I've got a copy of that, Vic. I'll send it to you. I've got a copy.
Brilliant.
Thanks.
So that's the best way to look at it. Okay, so let's test that a little bit more. So this is probably a bit more your street. 40-year-old alcohol-related liver cirrhosis, previous IVDU, hepatitis C untreated, and they asked you to go treat him. These are his blood tests. So if you guys want to have a quick look and tell me what you think this is showing. Anyone want to venture any answers, any guesses? So go through it systematically.
Yeah.
Is this a microcytic, normocytic, or macrocytic anemia?
Looks like, sorry. Normocytic anemia with some inflammatory markers going on.
Oh, yeah.
So
Are you sure?
Meticulous.
So what's the MCV?
Oh, MCV is low, sorry. So, yeah.
Oh, God, I'm looking at the wrong one. It's really
Low,
hard to see.
low hemoglobin, white cell counts are up, making me think it's some sort of infection or inflammatory process going on. His MCV is low. His CRP is up, so definitely some inflammatory process, and his ferritin is low, so low iron stores.
So what's your diagnosis?
So an iron deficiency.
Iron deficiency anemia.
Yeah.
Perfect. This is Bund or iron deficiency anemia. Of course, yes, you got a few things that are making it a bit mucky because you got that white cell count. But a lot of liver disease patients, they might have a UTI. But you can imagine, even though he's got a raised CRP, his ferritin is not gone up. So it's got to be iron deficiency anemia based on this. If you're not sure, you can do a transferrin saturation as well. But the overall picture is pointing to iron deficiency anemia. So this guy, if you think he's got an iron deficiency anemia, what do you think you should do next?
Gastro review, ask questions about bleeding, try and see where the blood loss is coming from, see whether it's a blood loss or whether it's something dietary.
Absolutely. So I think you're right. I think, like I said, the key here is knowing whether this is microcytic, normocytic, macrocytic. It doesn't sound like a thalassemia because the iron is low. So we're probably going down iron deficiency anemia, and the causes are multiple. It could be bleeding, which is a high chance if he's a cirrhotic, whether he's been bleeding a bit. Could he have a colon cancer? So you're right to refer gastro, consider OGD, colonoscopy, but you want to take a history too, because sometimes it's very simple. Oh, I'm vegan and I donate blood every 2 months or so. Well, that kind of answers your question. Or I've been peeing blood in my urine, time to do a urine dipstick. So while you rely on your blood tests, don't forget your clinical history. It's so crucial to give you the right answer, actually. So I think that's the take-home message from this one. But you're quite right. This is a test to show that you're reading the MCV and the things properly. Now, I struggled to find good guidelines or a nice systematic way, but these are actually from the Irish Transfusion Committee. I think they're quite useful. So they've got 3 different ones, one for normocytic, microcytic, and macro. And I can send you these slides if you prefer. But for the microcytic, I think the way they do it is quite good. If your ferritin is less than 30 and your CRP, because like I told you, it goes up with inflammation. If it's less than 30 and your transferrin saturations are very low, it is iron deficiency anemia. So you could give them iron, but you might want to refer to a gastroenterologist, especially if you think there's signs of bleeding, and you might go for a gastroscopy, colonoscopy. So that's the way we would manage iron deficiency anemia. But if the iron is normal, transferrin saturations are normal, then you got to start thinking about thalassemia. So this is kind of the way I would manage this all the time for microcytic anemia. So remember, this is where looking at your MCV is the key. Does that all make sense?
Yeah, it's really clear.
Very helpful.
It's very hard to find actually very clear ways of differentiating, but this one I found quite useful from the Irish committee. So normocytic anemia is actually probably something you will also get quite a lot, where the MCV is normal, they're a bit anemic. So this is how you do it. You still do the same basics. You check the iron, the CRP, and the transferrin saturation, because sometimes there's overlap. If you still have a low iron and a low transferrin saturation, even though it's normocytic, it can still be an iron deficiency anemia.
Yeah.
Okay? But if the iron is lowish, B12, folate, all normal, and he's got very bad kidney disease, think about that, because some people, when you've got chronic renal failure, your kidneys don't produce as much of the erythropoietin, which is a special hormone that increases your blood count. So it could be that that's causing it. So this is in the category, say you got someone who's hepatitis C but has got a EGFR of 40 and has got a long-standing anemia and a little bit of low iron. Think whether it's related to his chronic kidney disease. And the last category is where the iron is normal, the folate, B12 are normal, and it's what we call anemia of chronic disease. And you have this a lot in liver disease patients where they've got mild anemia, a bit like your thalassemia, no problem with it, nothing new is happening. They've had an OGD, colo, everything's normal. So could it just be the liver disease, anemia of chronic disease? And it's the same thing. The way you do that is you go back to basics. You do the iron studies, you do the B12 and folate, and then you see what's the clinical history, and that helps you. It all goes back to basics, knowing how to read the MCV and doing the right test. Does that make sense?
Yeah.
This is the last one. This is normally the most straightforward. If you got a macrocytosis, it's either going to be a folate deficiency, a B12 deficiency, or he's a heavy drinker or hypothyroidism, or he's on chemotherapy. So normally the macrocytic anemia is usually a bit easier to figure out, usually. Okay. So this hematologist gave these top tips, and one is if you know the general causes of most anemias, you will be a bit clear, like you know what thalassemia is due to now, so that helps. You've got to still take a decent history and sometimes examine the patient. Some things are important. For example, if you've got a liver patient with iron deficiency anemia, we'd still want to consider OGD colonoscopy to rule out cancer. So you mustn't forget those. But do the test logically, because there's no point in doing, electrophoresis, hemoglobin, and blood film if you got iron deficiency anemia, no thalassemia. So the test you choose should be right, because if you got, say, a macrocytic anemia, low B12, you don't need an OGD and colonoscopy for someone. So think about your test very logically. Ferritin by itself is not enough sometimes for iron deficiency anemia. So remember what I was telling you, look at the CRP, look at the transferrin saturations. You don't have to investigate all iron deficiency anemia. For example, You've got a 95-year-old guy. He's quite frail. He's got a bit of iron deficiency anemia, but he's well. Do you really want to subject him to gastro and colonoscopy? So it's all about treating the patient in front of you. And I'll put down a bit, like I said, these are the most common anemias you might find, but you can get all these ones as well, like B12, but they are not as common as the iron deficiency. But that's it in a nutshell, really. Well, I guess, like I said, you go back to basics. You learn to look at the MCV and do the right studies to give you the right answer.
Yeah,
I
that
would
is
say
so
that's
good.
probably where I leave it. I don't want to overdo it, but hopefully that's a little bit of a straightforward way of a practical way of how I look at anemia.
That is so
Thank you.
good.
Thank
Yeah.
you.
Those slides are the flow charts. I've got one of them, but I haven't seen this Irish one, so I think
Yeah,
they're
they're
going to
too
be
small.
really helpful.
I'm happy to I'll email it to you guys. I've got your email, so I can send it to Kathy and she can forward it to everyone if you want. And
Brilliant.
you will
Thank you.
you will get some more rare anemia sometimes, which you don't have to worry about, because for you it's more knowing how to classify them. If you can decide microcytic, normocytic, macrocytic, iron deficiency or not, you've probably done what you need to do. If it's a very fancy hematological problem, you got the blood film, you send to the hematologist. That's all you need. But it's recognizing it. That's the trick.
Thanks, Stephen.
Yeah, that's so much clearer. Thank you.
I'm
Yeah,
glad.
really, really good. Thank you
All
so
right.
much.
Well, it's been my pleasure. And like I said, we'll see how we go. But you know, if you need any more help with that, more than happy. But I'll probably record this video and give you the slides as well, so you can always share it with your colleagues.
Yeah,
Amazing. Thank you.
Really
Thanks
appreciate
ever so much.
You're
Bye.
welcome.
Bye, bye. Thank you.
Bye bye.